Right, hi everybody. You guys made it to the end. I am not, I'm going to say this up front, a behavioral health expert, though it's been fun to hear for the last, hour or so from those who are. There are 4 things and 4 reasons that I do care about this topic, and I want to kind of tell you each of those, but maybe to give you the headline up front. I'm running for Shasta County Board of Supervisors, and I do care about these issues and think we need to focus on these issues. So if anything, probably the most important thing that I think I can do here is just to let you know that this is important to me, and I think it's an important priority for the community. But let me now go way back to, so in school I studied psychology and mechanical engineering, which everybody, whenever I tell them that, is like, that's a very weird combination. What, do you want to become a psychologist for engineers? And I said, no, because engineers often don't share their emotions as someone who's, so I don't think that would be a very lucrative career, right? But that was kind of my start. And then ran into a number of family situations where, a family member got a call one day and went to the house of, I'm trying to protect some identities here, but went to the house of another family member and found that their family member had tried to commit suicide. They got there just in time, were able to stop that, prevent that. I remember in my first apartment with my wife after college, getting a call from a family member saying that, oh yeah, this close family member has been cutting themselves. And so this is a personal issue for me, as well as something that I studied to some extent within school. And so that's part of the reason why I care about it. Fast forward a few years out of school, I was working for a nonprofit, you could call it consulting firm. So we would work with other nonprofits, foundations, and philanthropists to figure out what are you doing that's effective, and then how do we help you grow that. And so we got the chance during that time to work with an organization some of you might know called Mental Health First Aid, which had started in Australia, I believe, and then had really, was trying to scale here in the United States, and so we helped them work on that. And so that was, a piece of what we did, but more broadly, we were often thinking about how do we address community or social challenges. And that's a little bit about what I want to share today. The 4th thing, though, is that in the last year, I got to join the men's advisory group here within the suicide prevention task force. That's probably not quite the right word, but within the Shasta County, that is working on an initiative called Captain Awesome, and so I do want to talk a little bit about that too. But let's jump in. So as I thought about my experience working for this nonprofit advisory firm, there was often these mindset shifts that we would help an organization make. And honestly, as I've been listening to you guys over the last hour or so, I feel like you're already there. So if you're like, oh, we got this, then great. And you can just be like, thanks for sharing, kind of complimenting us on what we're already doing. But maybe it will help to kind of put some language to these as well. So 4 shifts. The first one is from experience-based to evidence-based. And I've heard that language already today, but I think that's really important. We had a phrase that was scale what works. So the idea that you have to first figure out, is this actually effective? Is it making the difference that we think it is? Are we measuring the correct data? And then once you do, then you want to grow that and you want to scale that to meet the need. Oftentimes we can kind of, out of best intentions, be like, oh, this is what someone else has done before, or this is what we've always done, right? So it must be the best way to do it, right? Not necessarily. So we want to see, where is there evidence for that? And again, some of you all might be more experts on this than I am, but there's different levels of evidence, right? There's, oh, so-and-so told me they went to this program and it really changed their life. And it's like, oh, that's amazing, right? But that's an anecdote. That doesn't guarantee that it's going to be effective for the population. And so as you move to the right, there's higher levels of evidence. There's a descriptive study or kind of a qualitative study that's like, okay, we're getting some data seeming to suggest that there's evidence, but then what we would call, in my past line of work, the gold standard was a randomized control trial, where you actually have one group that's not going through the intervention and another group that is going through the intervention, and you randomize who gets to go in each one, so you're not like, oh, these are all the ones who are most likely to do well in this program. And then you see what are the results and you compare them. And so that's where you really start saying, oh, we know that this is actually effective. And then a meta-analysis is where you don't just have that one time, but you do that over many years, over many studies, and you're able to say, okay, we really feel strongly about this, that we can, if we do this with different populations, with different subpopulations I heard you talking about, that we feel pretty confident that this is going to work. And so as we think about what we're trying to implement, and as I think about, the county, what I'm hopeful for is, okay, how do we find what's evidence-based, what is the level of evidence behind it, and then let's grow those things and scale those things. All right, that was shift number 1. Shift number 2 was from serving to solving. And this, we were doing work with the Salvation Army, and they were focused on this idea of, they've been, I think it was the 1800s, definitely in the early 1900s, that they've been working on challenges around poverty and with low-income populations. And they had been serving them and doing, a great job of that, really meeting the needs. But what they found is that people would come through and they wouldn't necessarily get out of poverty. And so we worked with them to help make the shift from not just, okay, we don't want to just provide their immediate needs, but we want to see how can we help them get out of poverty and actually solve the problem that they're facing. And I think, there's a lot of, oftentimes in a community, there's a lot of great organizations that are doing their individual part to serve and that are providing great services that are helping people, but are we solving the problem? And ultimately, I like to think big picture. And so for me, I'm like, that's what I think we need to have a lens. A portion of the population needs to be thinking about that. Are we solving the problem? And so as I thought about that, and I was pulling some data on this, and again, you might say that's the wrong data, or because you probably know the data better, but I was looking at suicide rates by county, and this is from 2018 to 2020. And for Shasta County, and again, you guys all probably know this better than I do, but we're basically tied for the highest suicide rate in the state. And so when I think about going from serving to solving, part of what I would like to see is like, what would it look like for over the next 4 years for that to go down and for us to be ranked maybe around average, or at least closer to average? And how does the sum of the services that we're providing have an influence on that number? So that's what I'm hopeful for and what I'm thinking about in terms of serving to solving. One way that we used to do that is we would do something called a theory of change. Maybe some of you have heard of that. It's a little bit of an academic term, but basically it's the idea that you have inputs, which are like we have a certain number of clinicians. You have outputs, which are how many youth did we serve? And unfortunately, and I've heard the opposite here today, which I've been really encouraged by, but a lot of times they stop there. It's like, oh, well, our program, we served 25 people, or we served 2,500 people. And it's like, okay, great, but then what are the outcomes, right? How did it actually impact their lives? And so oftentimes you have an intermediate outcome, which in this case is like, we did a survey pre and post, and the post survey results suggested that they enjoyed it. But then we also want to do an ultimate outcome of like, what was the actual change in rate of suicidal ideation or something along those lines. So thinking across, that's what is the theory for how you take your inputs and you get all the way to the outputs? And is that spelled out in a way that makes sense where you can be like, oh yeah, I feel pretty confident that if we take this input and we get these outputs, we'll end up with this outcome. So that was shift number 2. Shift number 3, and sorry, I don't know your name, but you were talking a lot about this in terms of the collaborative and systems change, but it's going from single organizations to systems. And one of the things as I've been thinking about the homelessness space that I hear a lot is, okay, somebody decides, okay, I want to receive treatment for addiction, right? And so one thing that I've heard is that oftentimes there's a 30-day wait list. Mm-hmm. Right, and so at the time that they are like, yes, I do want to make a change, I want to get out of this, it's not available to them, right? And that's what you're saying, the number one need is access to those services. And then they go through it, but then what happens after they finish the 30 days of treatment? They go back to the street where they're in that environment that reinforces those, addictive behaviors. And so we have to think about it at a systems level, not just a single organization. That single organization that's providing, the addiction treatment might be doing an amazing job, but if we don't have the full system and people are falling through the cracks, then we're actually kind of using our resources inefficiently because I was talking to somebody who works on the street with people in homelessness, and he says the number of people who have been through a rehab program multiple times is actually really high. And so that's what we need to think about. And so when I think about systems, I like to think about these 4 components. So what is the goal of the system? And you all were talking about that too earlier, but then what are the handoffs so that people don't fall through the cracks? Okay, somebody goes through that program, who are they handing it off to? How do we make sure that there's coordination between that? And then bottlenecks is also a problem, and that's what we talked about. Bottlenecks means basically where in the system are you most likely to run into challenges where there's not enough capacity to deliver the service, right? Meaning like, oh, we have that wait list because there's not enough people providing those services to supply everyone that has a need for it. So that's a way that, some things we can think about in terms of the system components. And as I think about system problems, I was also looking at some data here. This is from the county health rankings. And they asked people, how many days during a 30-day period have you experienced poor mental health? So it's a little bit qualitative and self-reported, but you can see here, the darker means more days. And so Shasta County is about 9 from the bottom. So there's about 8 or 9 counties that I think have higher rates of poor mental health days. And so what I'm thinking about is like, okay, what would it look like? And this is more, I think, NAMI it seems like is more focused on severe mental illness. This is a little bit upstream in terms of just overall the community mental health. But what would it look like for us as a whole community to have mental health improve? Another thing that I was looking at, and this feels like a systems issue, and I honestly, and you might again say, this data seems weird, but here's a systems related issue that I'm like, oh, I don't know why this seems to be happening, and is this a good thing or a bad thing? But in terms of permanent conservatorships, the rate there for Shasta County has gone way up in the last about, I guess, 6-7 years. And so that's another thing where I'm thinking about the systems. Okay, you have the court system, you have law enforcement, the sheriff's office, you have behavioral health. All those systems are involved with that type of decision. So how are we working together? Is this a good thing? Are we like, yeah, this is good that this is happening, this was needed, or is it like, ooh, something is off here, but we have to think about the system. Okay. And then the last shift, which actually should be 4, but it says 3 up there, is from care to culture. And with all of these, it's not that we stop the former to begin, the 2, right? We don't stop caring for people and providing service to them, but I would encourage us, and the way I think about it is let's add in. We don't want to just serve, we want to solve also. And so from caring to culture, I think of culture as like the invisible force that is pushing us in a direction. And I think as we look at the what I would call maybe a mental health epidemic, in our nation that has, increased dramatically over the last few decades, that there is probably a cultural element to it. That there's some cultural element that is like, and multiple elements that is pushing people towards mental illness without us really realizing it. I think of culture as the repetitive actions and beliefs that we have. And so one way that I think we can think about culture is this initiative, which is Captain Awesome, which is run by Shasta County, and they are basically trying to show that men who are leaders in the community, because suicide rates, as I'm sure you all know better than I do, are much higher among men, at least in terms of successful, which is a weird word to attach to that, but yeah, men who are leaders in the community who are showing that you can seek help for mental health. And I don't know, honestly, how effective this is, but it's something I wanted to get involved in because I think part of it is we're going to need to shift the culture. What is an acceptable behavior? What are the belief systems that we have that are guiding us into a direction? And so this is kind of the final shift that I wanted to share with you all today is how do we think about shifting the culture in our community, and what do each of us, and I think that's really a sum of individual behaviors. What do each of us do on a daily basis that either encourages people towards mental wellness or encourages people towards mental illness? And so something there that, and if you're a guy, you can sign up to get your picture taken. I did it. It's not on the website yet, but yeah, you can do that. So I will, I'll leave with that. I don't know if there's any, obviously questions. If you want to ask me a question, you can, but again, I'm not the expert on behavioral health, but also as people who are really invested in this area, and as someone who's hoping to represent the county on this level. If you have things you think I should know or things that you think I should be looking into also, if we have time, but I'm happy to take a minute or two to hear from you all on that. Do you have something?
So, you were saying about the 30 days people that have addictions, and then they're put back to the streets. Well, I was homeless at one time, about 90 days ago, and I ended up in jail, and then I ended up getting a bed at the No Boundaries, which is a 6-month to a year-long program, and it's great. I mean, I've been clean 90 days. I'm loving it. I wish I was.
That's amazing, yeah. And I just talked with Christine last week, and I'm going to visit her and the folks living there next week, actually on Wednesday. So really, I think what's happening there, and it's awesome to hear your experience there, is exactly the type of thing that we need to fill in some of the gaps that we have had historically.
What board seat you running for?
District 4. In the back.
So, Mr. Plummer, I don't know if you were here for one of the presentations ahead of time. There was a young lady from Nevada. I was very impressed to hear how they implemented something in their county where the clinician, if that person is a client of the county mental health, how that clinician was automatically notified that their client was in jail. That there was this communication there, because in my experience in this county is that the jail is the new mental health facility. And that is unacceptable. These people do not have access to medical. Oh, they say, oh no, we give them their meds. No. I invite you to come and speak with some of the people here at our NAMI group, our support group. We wouldn't have a support group that day, but you're welcome to come and hear some of the stories that we have. Because the jail now, like I'm saying again, is the current hospital. And it just, I don't know what your feeling is about all this, but currently the climate here is, only the nonprofits should be the ones to take care of mental health. No, I'm not under that. I think that we have a county mental health for a reason. We have experts in that division. I don't think that my priest is going to help me with my, maybe they'll do an exorcism on it, but they're not going to do mental health. No, that's not going to happen. Okay, so I'm just asking you what you think about that.
Yeah, a few things that you mentioned. One, I just did a tour of the jail this past week, and it's funny the language you use, because they actually, one of the people who was giving me the tour, who works in the jail, he used almost the exact same language. He said the jail is the de facto mental health institution in our community. And they, from what I could tell, they don't think that's a good idea either. The people who are working in there, they're not equipped to, they're doing, as far as I can tell, the best they can. But yeah, I don't think that is, that's great. And they have 3 programming rooms that are all quite small in the jail, and one of them is closed right now with the floor that's closed. The other is for a jail-based competency program, which basically is just trying to get people fit to stand trial, which means that's not really kind of helping them, achieve mental health, really. And the other is for education program. Now that's going to be changing a little bit with the new courthouse. They're adding another programming room, but still, it's very limited ability to provide that type of program. So I think in terms of the jail, yeah, I'd love to see. And the way I think about it is, yes, jail should be a consequence for committing crime in the community, but it also should be a place where we are helping people have a better chance of becoming, healthy and effective in society. And so I would like to see that time that they spend there actually pushing them towards health, pushing them towards a job, or whatever it might be. In terms of the peer support group, yeah, I would love to come and hear from the folks that you're working with. And then on the last piece, which has to do with government versus nonprofits, I think as you shared earlier, it's going to take all of us. I mean, these are hard challenges. They're not just limited to Shasta County. They're not even just limited to California, though sometimes it can feel that way. But it's going to take all of us, and as you said, the county is, the main kind of entity through which that funding flows. And so I think they need to be a really important and key player there. And I think that nonprofits are a key piece of that. I mean, you guys heard from the Children's Legacy Center earlier, and some of the work they're doing is amazing too. And we need to have a good relationship between the county and the nonprofits, where nonprofits want to work with the county. I'm a little concerned that that's not happening as much, or that nonprofits are kind of pulling away for various reasons. But yeah, so I totally think that that is really important for both of those different entities to be at the table.
I have another question about this jail they have here. My understanding is the county of Shasta doesn't even own the jail. That's what church does. How does that happen?
Not true.
Yeah, I think the county owns the jail, and the county's working to build either additional addendum to the jail or a new facility, and so the jail is within the jurisdiction of the county. Yeah.
The problem isn't money, it's having people trained and being here to provide the services. There are a lot of care for people, but that system works against that, and we have to be more innovative in how we provide those services, because we're not having a lot of people come and want to stay here in this county.
Yeah, staffing is a huge challenge, both within the jail and more broadly within the county government, and even within the, in terms of healthcare providers. And so that is a key, I think it needs to be a key priority of any leader in the community who's working kind of in this space needs to be thinking about that, certainly.
How do you feel about lowering the standards of the job position in order to achieve some person to fill a spot nobody else will fill, and go ahead and lower the standards so that they can take that position? Where's your stance on that?
Yeah, generally I think that the standards that are in place are designed that they make sure that someone who takes the position is qualified to do the work of that position, and assuming that is the case, I think I know what you're alluding to, that should be upheld. Now, there might be situations in which we say, well, we can't fill it, and so is it better to have someone who's less qualified than to have no one? Now, before we ask ourselves that question, I think we should ask ourselves, why can't we fill it? And can we change anything else about why we can't fill it before we go there? But at the end of the day, if we can't fix this, which I think we probably could, but if we can't fix this, then yeah, I think probably at some point you're like, it's better to have someone than no one. And so, yeah.
I was just gonna make a comment. The slide that you showed that had the 4 areas, one was bottleneck. I can't remember.
Oh, yeah.
Anyway, I just really think, putting some of the presentations together today, we heard about a bottleneck from the residency program. 500 applications for 4 positions for those residencies. I really think we heard very clearly about a bottleneck today, and so just to put that on any leader's radar, then maybe that's something we need to look at, is how do people get to become psychiatrists, and very clear bottleneck.
Yeah, that's great. I heard in terms of nurses, for example, I was talking with someone the other day, actually an ER nurse invited me to come to the ER to experience that and hear from her. And there's a nurse shortage as well, and so it's like, well, we have 2 great programs here as far as I know, Simpson and Shasta College. Why do we have a shortage? And what they suggested, and I haven't kind of validated this, but is that there's a shortage in terms of professors. And so we have more people who want to get into those programs, but we don't have enough people to teach it, so we've capped the students. And so that's the kind of system thinking that we need to be doing as a community, is figuring out, okay, this isn't working, well, why? And then kind of trace it back, and where in the system do we have a shortfall or a problem? Yeah. Teachers, yeah, absolutely. Yeah. Well, thanks everybody. Thanks for giving me the opportunity to share about that.